Thank you very much, dear Mr. Chairman, Professor Samir, and dear Mr. Chairman, Professor Amrin Maliki. And I'm going to talk about women and obesity, what lies beneath. More than 100 years ago, obesity was looked as a sign of beauty. It was a benefit and advantage and not a disadvantage. And obesity in 2015, the last WHO obesity figures were approximately 2.3 billion adults having overweight, and at least 700 million are obese adults, and most of these 700 million are women. These are the data for the Middle East, but usually in the Middle East there is no updated data. And for Egypt, this is the data for 2005, and we are waiting for our presidential initiative for obesity management and obesity prevalence. And this study is very interesting about overweight and underweight prevalence in women between 20 and 49 years in 36 developing countries ranked by the gross national income. And in this study, Egypt had the highest number of overweight and obesity among those females and the least percentage of underweight in females. We are living in an obesogenic environment for females due to urbanization, sedentary lifestyle, private cars, television, household appliances, less physical activity, high caloric diet, high fat intake, and women are more likely to be overweight or obese due to cultural aspects and perceptions. Obesity in countries like Gulf, Bahrain, Kuwait, Oman, Qatar, Saudi Arabia, and United Arab Emirates are due to very high intake of energy-dense foods, low fruit and vegetables, and aggressive commercial marketing of processed food. This is called an advanced nutritional transitional stage. High level of overnutrition and obesity and dietary risk factors for those countries, while in countries like Egypt, Iran, Jordan, Libya, Lebanon, Morocco, Palestine, Syria, and Tunisia, there is early nutrition transitional stage, but also there is coexistence of increased dietary energy, fats, and carbohydrates, and marketing of junk food and fast food and commercial marketing of dangerous foods full of fats and carbs. When we discuss the lifestyle of Egyptians, we find that the percentage of population who ate 5 or more combined servings of fruits and vegetables are around 20% of the population, whether males or females. For physical activity, this is the percentage of a population with low level of activity, 45% in males and 57% in females. For overweight and obesity, in this measurement, there was 60% of males overweight, 21% of males obese, in females 72% females overweight, and 39% female obesity. These are the complications of obesity, the clear and present danger: cardiovascular disease, coronary artery disease, angina, myocardial infarction, heart failure, arrhythmia, and sudden death. Hypertension: for every 10% increase in weight, will lead to increase 6 millimeter mercury, and decrease in body weight will lead to decrease in blood pressure. DVT, respiratory complications in the form of sleep apnea, impaired respiratory functions, and Pickwickian syndrome. And this is a picture of the sleep apnea to the right side, and the picture of the Pickwickian character in Charles Dickens' story, the novel of Charles Dickens, when he described a character of obese person and with abdominal obesity, and he sleeps while he's sitting. This is Mr. Pickwickian, the Pickwickian syndrome. These are other complications of obesity: hepatocellular and biliary, like fatty liver, hepatitis, calcular cholecystitis, arthritis, especially weight-bearing joints, cancers, breast, colon, prostate, uterus, ovary, and others, diabetes mellitus. 80% of diabetics are obese, hyperlipidemia, especially hypertriglyceridemia, infertility, abortions, birth defects. Obese mothers more than 30 BMI may have birth defects in their newborn. Increased mortality happens above the BMI of 30. This is a relation between BMI and chronic diseases among males and females, and we could find a strong correlation between obesity and type 2 diabetes in both women and men, followed by cholecystitis, hypertension, and coronary heart disease. This is again the relationship between BMI and the risk of type 2 diabetes. When we compare those with BMI more than 35 to those with BMI less than 22, we're going to find 93 times increased risk for diabetes in females and 42 times increased risk for diabetes in males. These are the cancers linked to obesity in females: breast cancer, colonic, uterus, gallbladder, ovary, upper GIT, pancreas, and renal cell carcinoma, and in males, prostatic cancer. Other complications of obesity: physical complications, sensation of tiredness all the time. We know this complaint in our patients, in our clinics: breathlessness, varicose veins, headache, edema, cellulitis, sweating, interpsychose, stress, incontinence, and social complications: sense of isolation, unemployment, family or marital stresses, financial stresses, and depression. Abdominal obesity and cardiometabolic syndrome. Abdominal obesity increase the risk of cardiovascular events. This was shown in the HOPE study. Abdominal obesity increase the risk for developing type 2 diabetes, and abdominal obesity predicts outcomes such as sudden death in the Paris prospective study. Abdominal obesity and increased risk of cardiovascular disease with circumference was an independent risk for cardio or coronary heart disease. These ladies usually before marriage take care of themselves, and after marriage, 10 years after marriage, we don't want to see this picture. The twin of epidemic of obesity and type 2 diabetes are on the rise. From 1986 to 2000, the prevalence of BMI 30 is doubled. BMI more than 40 was quadrupled. Extreme obesity of BMI 50 or more increased 5-folds. The majority of obese population, the average life expectancy is reduced by 9 years in women and 12 years in males. One year after marriage, starting the bad pathway. Women and obesity, it's not just an issue of size. We need to change the priority of physician given to the obese female. يعني احنا عندنا بيزعلوا لما نقول لهم الوزن وكده. It's not just a matter of size. Women and obesity, it's more than an issue of size. Greater health consequences, greater psychological consequences, and the specific female issues like infertility, polycystic ovary syndrome, pregnancy complications, influence on fetal development, and complications related to menopause and female cancers. Obesity affects women disproportionately, and it is a life cycle of medical risk, starting from infancy, advancing to adulthood, obesity, and psychological health and reproductive health. Fertility with assisted reproduction. The pregnancy rates halved for obese women. When obese women seek treatment of infertility, usually the gynecologist advises to lose weight because fertility will be reduced to 50% in obese females. Body mass index predicts infertility in females with or without polycystic ovary syndrome. With pregnancy, in early pregnancy, there is medical complication in the form of miscarriage or twinning and technical complication due to difficult ultrasound. Antenatal, the pregnancy-induced hypertension, the preeclampsia, the gestational diabetes, and the venous thromboembolism. Interpartum, higher rate for induction of labor, planned and acute cesarean section, assisted delivery, vaginal tears, and operative complications usually happen in obese females. Postpartum, hemorrhage, infection, and venous thromboembolism. And fetal complications in the form of macrosomia, congenital abnormalities, fetal distresses, perinatal morbidity and mortality, and birth injuries. And gestational diabetes occurs in 4% of all pregnancies, and overweight females have 17% risk of gestational diabetes, and the risk is increased to be type 2 diabetes in the future in those obese females. There is metabolic defects during pregnancy and effects during pregnancy affecting the offspring. For mature and aging women, there is increased risk of obesity-related comorbidities with aging, like type 2 diabetes, hypertension, and cardiovascular disease, and increased risk of all types of cancers, like we mentioned, uterine, kidney, breast, postmenopausal type of the cancer, breast, and cervix. This is the increased risk for most cancers, and we can find that the uterine cancer is very much increased in incidence in obese females, followed by the cervix cancer and followed by the breast cancer. And in the breast cancer, it's not only increased risk, but late diagnosis of the breast cancer. In elder women, increased risk of cognitive dysfunction and dementia with aging, negative implication on life expectancy. This study showed that the risk of Alzheimer's disease in elderly with or without metabolic syndrome, and it was found to be increased in females with metabolic syndrome. The dementia was increased, while in male there was no difference between males with metabolic syndrome or not having a metabolic syndrome. Obesity and Alzheimer's disease, it is an independent risk factor for Alzheimer's disease, and it is associated with increased risk of dementia and Alzheimer's disease in cross-sectional and longitudinal studies. Then it affects all the life cycle of the female, reducing the life expectancy, the cognition, the cancer, the cardiovascular disease, other chronic disease, psychological effects during adulthood and young adulthood, effects on reproductive health, and effect on the newborn and the baby. Obesity has a solution. This is a famous actor before obesity management and after obesity management. Another famous celebrity. Then obesity has a treatment. Thank you very much.
Thank you very much, Professor Inass, for the nice and presentation and keeping on time, and I guess we have a couple of minutes for discussion before moving to the next talk. Any question addressed to Professor Shaltout? Let me start with a question to Professor Shaltout till you gather your own. Do you think the threshold for obese ladies in Egypt to go for bariatric surgery or to start, say, an effective GLP-1 analog treatment, is it different from men in Egypt? I mean, do they go for surgery and starting treatment more than men? What's your opinion?
Yes, they seek obesity management more than men. Before the introduction of GLP-1 receptor agonist as a treatment of obesity, usually females think about bariatric surgery, but now they have the option to take medication instead of going to an irreversible surgery. So it's better to start with medication and to try if they are responder with the GLP-1 receptor agonist, because this is a confirmed medication and approved by FDA. So they should seek at first to try medical treatment, because medical treatment can be stopped anytime, while bariatric surgery is having too much complications, operative complication, early post-operative complication, and 1 year post-operative complication, and late post-operative complication. And it is irreversible. But the treatment with GLP-1 receptor agonist is having less side effects and can be stopped anytime.
Thank you. Got any other questions before we move to the